the collar issue.
So I'm hopeful that we're going to get great responses. My colleague, Dr. Augustine, has been working on urging and mentoring people in their replies. Jim, what's our latest count?
I don't have a count. I haven't heard from your other faculty members, Corey. I'm sorry.
That's okay. That's okay. For those of you that are unaware, we are trying to look at what we as a group do when a C-collar doesn't fit, doesn't work, can't be tolerated, to try to get a national feel for what is standard, or is it just everybody does it their own way? So if you don't mind replying, it's a Survey Monkey that takes maybe, I don't know, 40 seconds. And if you want another copy, or you want me to fill out your answers and make stuff up, just let me know.
Okay, got it.
Which is the way research should be done.
Okay, yeah. Well, I think we already know the answer, which is everybody does what they want, but we'll see how that, we'll document that, right? We'll see. Hey, so let's do this. Mick just said he never got a link. So just if you want to send it off to Mick Malloy, if you wanted to do that as well. Okay, so that would be good. And we'll see what's happened over in Ireland. All right, so I have a few people that have to get off early, so I'm going to go ahead and do that. I know of Glenn Asada. I know David has to be off in within about 45 minutes or so. Anybody else that has to get off early, so I can make sure I prioritize you? Okay, with that, I'm waiting for Eileen to get on. She's going to give a formal presentation on monkeypox, and things are evolving there, by the way. And you'll hear it here first on Eagles, probably. But in the meantime, let's go ahead and since Glenn is in the epicenter and as usual, and has to get off by noon his time, like about next 20 minutes, let me go ahead and go to New York City and see what's the latest going on and what do you think is going to happen in your meeting, Glenn?
Hey, everybody. Hope all's well. So, yet another monkeypox meeting. We're up to about 2,000 cases here in New York City. So that's what, 25% of the US cases. So we, once again, as you said, are the epicenter, unfortunately. I'd really love to hand that off to other people, but that is what it is. So one of the things at today's meeting is they want to see if our medics can vaccinate against monkeypox. And, going off, that's our health and hospitals and our DOH that have popped up these pods. They're anticipating some more vaccinations come in. And, it's not as simple as just doing it, because the vaccination allowance by the state governor was for influenza and COVID. So they have to still work on getting this done, but it looks like it's going to probably happen. Then apparently some of it's sub-Q. Our medics can do sub-Q, but we don't have any protocols that are sub-Q at this point. So we'd have to do another training piece of it, and everything is training. So that's probably going to be the meeting that's coming up. We are again in our third or fourth heat wave, and the call volume has reflected that, about 4,900 calls a day. And we keep plugging along.
Okay. So it is interesting, and I'm gonna get suspicious more and more that this thing is more transmissible than we originally thought. We'll see. And so I'm just sorry what you're going through. Now, hey, let me jump over real quickly to John Jew. John, so if I got a smallpox vaccination as a kid, am I relatively protected or completely protected or not protected at all?
You're probably protected, Paul. I guess you have to define protection. You're probably going to come down with monkeypox, but your chances of dying from monkeypox are much less than even the persons that are not protected as well. So you have some residual protection. I've received two smallpox vaccines, but the last one was like 20 years ago. So hopefully my T cells will remember. The official ones is that I think every 3 years, if you're in deep exposure, there's a lot of controversy right now. And this is speaking to Glenn, and regarding if the vaccinators need to have monkeypox vaccine or smallpox vaccine to be safe. Does that make sense as well? So that is, honestly, I'm not advising our crews, our fire EMS crews, to do vaccination without prior vaccination.
Yeah. So that's it. So get them vaccinated. And that's that was a strategy we used. Remember after 9/11, we were all worried about the bioterrorism. And what our plan was that we would basically have the firefighters and even their families vaccinated first. And
Correct.
then we would get on and use those folks for doing the mass vaccinations, because you had 60 people working in the health department that cover several million people in the county. And so we did probably
Yeah.
need for that mass casualty
Yeah.
situation, right? So
Yeah,
And
for
I
the,
thought-
for the
John,
audience, yeah, go ahead, Glenn.
John, is that mainly because the people that the medics would be vaccinating potentially could have monkeypox, or is it more from the vaccine interaction?
Oh, it's people that have been, who, either vaccinated could have monkeypox.
Gotcha.
It's a subclinical area here as well. And so, the point here, I just want to be very transparent. CDC does not recommend, or advocate monkeypox vaccine for the vaccinators. WHO does as
Okay.
well. So I think if it's like going up the uphill thing. Like Paul, I'm very suspicious that the transmissibility of this virus is more than quote unquote close contact. There's something much more going on. It doesn't fit the pattern, as Paul suggested.
guess is that it's going to be also vapors in there, you know. So,
Yeah,
you know,
there's a lot more to the outbreak than direct transmission.
yeah, exactly.
And thank you, John, that's great. I'll take that to my meeting.
Yeah.
The other thing is with the smallpox, after 9/11, we were afraid that we're going to get hit with smallpox. So we actually had a campaign to vaccinate, our medics and EMTs, so
Right.
that there would be smallpox units potentially to go. But the number of people who volunteered to get it was very, very low.
Yeah, but I think what Paul's trying to say is if you've had smallpox vaccine, especially if you're older, you stand a better chance than the individuals that have not had smallpox vaccine. Just keep in
Yeah,
mind.
absolutely, yeah. But again,
Yeah.
in our preparation for smallpox attack, we were trying to get, our workforce, but it wasn't that
So
successful.
Glenn, I don't know if you heard me or not, but I was saying the same thing after 9/11. We were looking at vaccinating our firefighters who do the job for us. And then we also offered to vaccinate their family members as well. That was a kind of a side motivator, just so you're aware of that. So I'm going to jump
Yeah,
over.
just to interrupt there for a second, I'd be
Yeah.
just interested, just from the pure non-scientific data, how many people on this call got revaccinated during that program? I mean, I did. And
I did as well, Rob.
Yeah. I'd had two myself. I was 11 years old at
Yeah.
the time. So that was it's 1961. So
Yeah.
yeah.
I'm saying it tongue in cheek. This is a rare time. Instead of the residents, is that I'll take this case rather than you first as well. So.
That's funny. All right.
Hey, I sat at Emory when we had that discussion, and they were discussing smallpox vaccinations for Emory Health staff. And the experts in smallpox insisted that that was not a wise move, that the complications of immunization, the potential infectivity of the people that were vaccinated was not needed. And that if smallpox did occur, that ring vaccination programs, especially in a country like ours, could be done successfully. So they recommended they recommended no immunization program for healthcare providers, other than continued for people who were doing the research.
Thanks, Jim. I think there's controversy here.
Yeah. So let me jump over to a person who has dabbled in both public health and EMS, namely David Pearce. David, where are you guys going on this one?
Hi, Paul. Good morning, everybody. So in Houston, we've got tiny numbers compared to New York City. So City of Houston has 177 cases as of 5:30 last night. There's another 22 cases in the county. We've got some vaccination projects up and going. Interestingly, we've got EpiLinks, as far as I know, for all but one of our cases. So we only have one case that we can't figure out how that individual became infected. My big concern, I'll throw this out, is one of our cases is we have two female cases. One is a mother of 4 children. 3 of them are under the age of 8 and will be going to school. And so we're worried about transmission within the household and then the kids going to school. And so this conversation of, do we really know how it spreads? I'm really got, my skin is crawling if we have spread within an elementary school. And I'm thinking, pre-K, kindergarten, first graders, there's a lot of hugging and sitting close and best buddies and sharing sandwiches and all sorts of innocent behaviors that a virus might take advantage of. And how is a society, how's a community going to respond if we get a monkeypox spread amongst little kids in a school? I think they're going to go crazy. So, yeah, that's what I'm worried about. That's what's got me. Anybody, John? Anybody got any thoughts on spread with the school children? And then high school and college kids. That's a whole nother risk area, right? Because yeah, they do engage in high risk behaviors.
Yeah, I mean, I'll defer to Eileen, but for me, that is my worst nightmare. For it, the monkeypox, if it causes severe disease and death, it's going to be in a very young age group as well as the very old here as well. The second one is that, as everybody knows, direct contact is probably the primary method of transmission, is almost impossible. The third one is that the incubation period, a lot of them have not had significant, I would say, rash, and the incubation period is subtle at times as well. So I think if I were you, and obviously I'm glad I'm not you right now, that I would probably just say sort of quarantine that family right now.
Yeah.
Hey, David, what are some of those risky behaviors that college kids have? Is it getting pizza a lot late at night?
No, I'm thinking more, contact sports, football, basketball,
Yes,
contact sports.
Yeah, that's what I thought. Okay. Go
But I
ahead.
think I want to just reiterate, I think what David's really talking about is widespread within our population right now. And honestly, I think the virus is out of the controllable sphere right now.
Yeah. And you're thinking where I'm thinking too, that this may be more to it than
Oh, absolutely. There's much more to it than direct contact, but
all
I think
right.
David has the epi information.
All right, so let's talk to another health director. Let's go out to the state of Hawaii, if you don't mind. Since you're up for us, we're up for you.
We've had 12 cases in Hawaii. We can link most of them to contact or to a specific event, but we have a couple of travel cases, and then we have a couple of cases that are community spread. So we know that there's likely more out there than that because of those two community cases. We're starting some mass vaccination clinics. Been doing that over the weekend with limited vaccine supply. So we haven't been vaccinating the public health nurses that are administering vaccines. Just we didn't feel like we had enough to do that. But interesting that the WHO is recommending that, because CDC is definitely not recommending that.
Okay, any reaction to that? If not, I'll jump over to the health director over Milwaukee, or at least the advisor on public health in Milwaukee, right?
That's right. Yeah, we're
I'm
working
sorry,
through-
chief advisor. I am so sorry.
it's a mouthful. It wasn't my choice. Yeah, so yeah, we're working through the same things as everybody else. So our COVID levels are still high. So trying to keep messaging going there, getting ready for back to school, which a lot of complexity with testing in particular, and a lot of dynamic changes. I'm sure everybody is feeling this with what schools are doing around isolation and quarantine and vaccination and messaging and masking, and a long list. And in Milwaukee County, we have 14 different municipalities, 11 different health departments, which is unusual for a single county. So a lot of differences of opinions. As far as monkeypox, working on wrapping our head a little better around the data, in particular, which is, it feels like the beginning of COVID when there's a lot of data there, but it's hard to get it all together in one place and understand exactly what's going on. So working on that, and then limited vaccine supply and messaging there. So from a infectious disease public health standpoint, that's kind of what's going on. And then of course there's the gun violence and the reckless driving and all that stuff on the side that, slowly worsening rather than rapidly worsening.
Yep. Yeah, absolutely. So let's do this. I'm going to jump over to, see, who was it? I just wanted to, Mick Malloy over in Ireland. How's it evolving over there? More slowly than here, or are you seeing your cases there as well?
Seen cases, but it's very small numbers for really hasn't been the outbreaks that have been in other cities. And I think most of the cases have been imported. people on holiday weekends in the UK and in Germany coming back after festivals. But the
Yeah.
number of cases is very small.
Okay, got it. Okay, fantastic. So anything else you can report on from Ireland while I get you on then before I want to hop back over
our-
David's question. I'm going to pitch it to John again, if you could see that in the chat, John. But go ahead. Anything else going on? from you?
Two things, bit of a crisis in health staffing at the moment, and the Minister for Health is looking at bringing in some new regulations that if people are certified emergency attendings in other countries and want to come and work in Ireland, they're going to really dramatically reduce the paperwork to get here. So if anybody was ever thinking of taking a jump and a leap, please get in touch with me, because there seems to be a lot of posts on the offing at the moment.
Hey, and Mick,
And
I
it's-
apologize, but you have a lot of background noise, so we weren't quite clear on what the new regulations that the health minister wanted to bring in.
I don't know either yet, but he's going to reduce the paperwork required to become certified in Ireland to practice as an attending specialist.
Okay, got it. And what kind of specialist, like a family medicine specialist? you
No,
said?
no, emergency medicine in particular.
Oh, wow. Okay, got it. Interesting. All righty.
So there's a big shortage, and they can see a big need, and they've been hammered this year, and they suddenly realized the message we've been given. Apologies for the background noise. I am on a vacation for the first time in 3 years, so I'm calling you from the pool, so you can hear all the babies crying in the background.
So where did you guys go off to? That's more interesting. Where?
Portugal, Villamoura in Portugal. Absolutely beautiful.
Whereabouts in Portugal are you?
The Algarve.
Oh, fantastic then. Okay, good.
Yeah.
Great area. All right. And
We're
then
out fishing tomorrow for 6 hours.
Okay, good. And you will be there when I arrive there on September 6th, I hope, right? Or wherever.
I will be.
Yeah. So I'll call you in the next, when's a good time for me to call you? Because obviously I don't want to bother you during vacation. You'll be back next week?
No, I'm back on the 20th. I got another conference call after this. We want to call later anytime, no problem.
Okay. All right. Good. All
And so
right.
the second bit of news, we have a World Disaster and Emergency Medicine Conference in Killarney, Kerry next year.
Okay.
Abstracts accepted up until I think November the 7th. Anybody interested, again, just get in touch with me. I can put you in touch with the guys who are doing the registration, but it's going to be quite the event.
If you would you send a copy of that and then to Jim Augustine, he can send it out to the rest of us. Okay.
Absolutely.
All right, good. Fantastic. All right. So let's see. Hey, so John answered the question about you could do both sub-Q and IM, correct? Go ahead. What was the question again, John, put to you by Libby?
I think I'm not sure if Libby, yeah, you can, so the intradermal route is a proposed route. Obviously, you require much less, but we do not have any real good animal data on intradermal route versus sub-Q versus IM. The article I'm going to attach in the chat, it actually looks at those routes literally, and the immune response difference is not surprisingly different by the route as well. So rather than spend a lot of time, it's a sort of a difficult read, but it's worth reading here as well. Okay, so the bottom line is that the intradermal route, the major benefit is that you get more vaccine, which is currently the limiting factor right now. The second issue is, do you get protection? Honestly, I'm not sure if you get the protection. There's not a lot of even phase 3 animal data on the protection here as well. So I think this is really an experimental proposal right now.
All right. Hey, and then Glenn, I know you have to get off. We're going to get a nice review later, I think, from Eileen. I thought she'd be on by now. But maybe check out the video later on and keep up to date on things, or I'll call you later. So
Thank you. Yeah, it's great information.
Yeah. So has this been helpful to you? I hope this has been helpful to you before you go off to your meeting. So
Yeah.
Thanks for alerting me to that. I appreciate it. All right. Well, okay. I think it's going to be a little bit more worrisome, but you guys kind of predicted that, you and John and you and Eileen.
Yeah.
And I remember back in April, because Jim Augustine, when were we in out at Dulles Airport area, wherever it was? I forgot the name of the city. But yeah, how long was that? In April, end of April, I think, right?
It was beginning of May. Yep.
Yeah, I remember, because we were on that call, from their headquarters there at Chantilly, and we're able, and then you guys were predicting where we're going here. So even though it was not thought of as being so worrisome at the time. All right, well, okay, so let's see. I wanted to talk to a couple other folks that I wanted to see here. So Rob, I will bounce back to you, Rob Dunn, since you have your EMS fellow on. Thank you for letting me know who that is. So that was helpful, but put that in the notes there. So what happened to you? Has there been any things that have you outside your office today? Rob, are you there?
Yeah, so COVID finally bit me. I am in isolation, doing well. I have a few comorbidities in age, so I am on Paxlovid for my doctor, which, hopefully it's working. Gives you a terrible taste in your mouth if you
It's like a bitter taste, isn't it?
God. And I just want to say something about monkeypox, because of course we've been managing this in Detroit as well, and people talk about the number of cases they have. We've really been trying to estimate the actual number of cases we have rather than just the positives.
Good point.
And what we've seen is that many of our health systems have no clue how to send the test either to any of the private labs or our state lab. And we've had a fairly large number of tests rejected in patients that sounded like they had a pretty high pretest probability. And we're certainly seeing a lot of folks that have a good story for exposure. We're basically vaccinating as fast as we can get vaccine. We didn't have a great allocation to our state. We've been doing outreach events at some high-risk areas that have been associated with definite monkeypox cases, but we think we're kind of just seeing the tip of the iceberg on our positives. So.
Yeah. So tell me, how does one test for it? That's actually a good point. What's the test involved?
Yeah, so it's a dry swab and a wet swab. Every lab is going to handle it a little bit differently. For the paperwork, most of our health systems are using private labs and they don't need to use the state paperwork. Our state had a series of kind of burdensome paperwork, although they did back down on some of that. And then it needs to be sent out promptly, or the wet part of it, the wet viral swab needs to be refrigerated if you don't send it out promptly.
And what is it a swab of? Is it a swab of one of the lesions? Is that?
Yes, swabs of the lesions.
Yep. Okay, got it.
And frankly, what we've encouraged every place to do is give a cheat sheet that could be posted in their clinics or emergency departments so people actually do the right thing. Because we had a couple of cases where the doc trying to do the right thing called the lab, but the lab person gave them bad information because they just didn't know. So we've tried to use our public health folks to get out and interface with all of our private health systems to say how to do a test right.
So I think you're raising a great point. I think it is larger numbers than we know and not just because of the testing, but other issues as well, as in terms of not recognizing it. Ben, you wanted to make a comment here or ask a question?
Yeah, no, I was just curious, Rob. So are they getting rejected because they were collected wrong, or the paperwork is wrong, or they're not refrigerating them, or all the above?
All the above, mostly collected wrong, mostly wrong swab, wrong tube.
Okay, thanks.
Which was frustrating because some of this was happening like literally last weekend. I mean, we're weeks into this thing and we have places that still haven't provided much guidance to their providers.
Okay, got it. Hey, I just want to jump over before I go on to other players. Bjorn Peterson, thanks for joining us today. Can you remind everybody who you are? For those who haven't met you yet? Okay.
Yeah, Bjorn Peterson. I took over for we call him beloved professor, RJ Frasconi, here in St. Paul, Minnesota. I work with Regions Hospital EMS. We provide medical direction to St. Paul Fire, among a bunch of other suburban agencies, as well as Lifelink 3 air medical transport in Minnesota and Wisconsin.
All right, well, thanks for joining us. Anything to report from your neck of the woods? I'll be up there, by the way, in about a month or so. So I hope to meet you in person. So
absolutely, yeah. No, we're gearing up for the Minnesota State Fair, best state fair in the country. If you haven't been,
yeah, that's right. It is the best one. I forgot.
Sorry, Ben. I know Wisconsin tries to rival, but doesn't quite come as close. So our office provides all the medical care on site for that. So that ends up being a busy month for us. But otherwise, we're just trolling along. We don't have a lot of monkeypox to report. COVID seems to be down a little bit. Everything's going well.
So how about you? Have you ever caught COVID as far as you know?
I did. I got the Delta last August.
Okay, good.
I've made it through this phase so far unscathed. My wife had it. She's been sick for about 2 weeks, just kind of fatigue and
Oh.
dizziness mostly, but I'm
Wow.
I'm still pure.
Well, let us know if she continues into the long COVID phase, because we may have some suggestions about how to fix that. And by the way, Rob, just so you know, you're not alone. David, tell them a little bit about what happened with you. You have an STD, correct? David Miramontes? Just for
I
the-
got an STD. I got an STD, a spousally transmitted disease. My wife was traveling with me and got sick, and she got a little flu and like illness. So we're testing and testing and testing. Finally, she popped positive. So I started testing and testing and testing, and I got mildly ill. But thank goodness for Paxlovid. And Rob, I can tell you that taste in your mouth is terrible, but it goes away the minute you stop taking the med.
Yeah, it's interesting because no one ever talks about that bitter taste that's there. And but it is interesting. Huh? It is. All right. Hey, John, do you know what that's from? Why do you get that? Is there some kind of reaction that leaves a taste like that? Are you familiar with it? It's like a very bitter taste.
Yeah, I've had the reports of that before, but no, I don't know.
That'd be
The
kind of a
mechanism.
fun thing
Yeah.
to be able to explain. It'd be great at cocktail parties, right?
Yeah.
Are you guys
All right.
talking about Paxlovid?
Yes.
Yeah,
Yes.
yeah. Every single patient I've given it to complains of the metallic taste. I have not had
Yeah.
one person that did not complain. Well, or explain.
Yeah, that's right. It'd be great to know why they get it and be able to tell them that, or make up something that makes it sound really cool. That means, oh, it's working, right? Whatever it may be. All right. Well, listen, okay, welcome, Eileen. Let me see if I want to capture a couple other people who may have to get off before I turn it over to you. First of all, Chuck Mason, I haven't talked to you for a while. What's happening in Little Rock? Chuck, are you there still? Or am I catching you off guard? You never know when I'm going to pop in on anybody here. Chuck, are you there? Chuck Mason? All right, if not, let's go over to Fiona. You may have only a little bit of time. Fiona, what's happening in your world over in UK?
Yeah.
And by the way, I don't know if you know, but the Yanks have invaded there. I hear Peter Antavi landed there this morning. Okay, so.
Oh, I'll get the fuzz out. Keep the tabs on him. So thanks, Paul. Good afternoon, everybody. Yeah, so just a couple of updates from my corner of the world. We're facing another heat wave. So it's pretty unusual that we get temperatures in excess of 30. We have never had temperatures in excess of 40. So climate change is really starting to impact on us. And we are seeing an increase in a number of excess deaths. Interestingly, we're seeing more deaths at home. They don't seem to be recently discharged from hospital or in care homes. Monkeypox is plateauing in the UK. 75% of the cases have been in London. There are only relatively few outside of London. And so it's less of a worry for us now. COVID is again going down across the country. About 7% of our acute beds have got COVID patients, although that's higher in some areas, but we're anticipating another wave in the autumn. The NHS is trying to put out some good news at the moment because there isn't an awful lot of good news around. And we have reduced the number of people who've been waiting for surgery for more than 2 years by 90%. But there's still a hell of a lot of people waiting for more than a year for routine surgery.
Okay, so let's back up to your statement about that we're anticipating another wave in the fall. Is that because of the typical indoors stuff when the weather gets cold, or is there some information that you got a new variant coming in from India, or what is the thinking?
No, it's just winter equals more respiratory viruses, more people in close contact together because it's cold and they're all indoors, less time in open spaces.
Okay, got it. All right, thanks. And hopefully you're doing well, right? We've been going around and polling different people that got the virus at one point. Did you ever catch it yourself? COVID? No.
Not yet. Not yet.
Okay, and next week you will. We just want you to know. That's the way it seems to be the pattern. Everybody's catching up with it. So, all right. Well, listen, thank you very much. It's great to see you, and hang in here, and we'll see how it goes. Sandy Schneider, how are you doing on time? Do I go over to you now before I get to Eileen?
It's up to you. I'm fine.
Okay, good. All right. Well, let's go ahead. And Eileen, how are you doing on time?
Oh, I'm fine. I don't need to go right away if you have somebody else
Yeah,
that's more.
we had a lot of discussion about monkeypox, just so you know, before you got on, but it was good, and John did a great job. But I want to get more of a formal report for you. So let me see if there's anybody else that wanted to sort of quickly catch before we go into that with you. Jim, anything we need to hear about from either the International Association of Firefighters or Fire Chiefs?
Yeah, both of them have been meeting regularly, trying to put after action reports together. Just a little note, what was the COVID task force is going to become the Medical Intelligence Committee. And that may be a model for others in their states or big local areas. You know, Dave Pearce and Ben Weston and others have really good methods for bringing people together. But Medical Intelligence Committee is a good evolution of what were our COVID task forces. And Paul, it's about people right now. Big concern about being able to keep people in the industry and attract them, because a lot of our recruiting efforts are coming up dry.
Well, maybe we could do what they're doing in Ireland and lower the standards, right? Just being sarcastic. Sorry about that.
Yeah.
Yeah, it is that.
Thanks,
That
Paul.
is. Yeah. No. Okay.
I
Anything
have
else?
to object, Paul. There's no
Yeah,
lowering
yeah,
of the
please.
standards, they're just lowering of the paperwork.
Yeah. Oh, the paperwork. Sorry. Okay. Good. Thank you so much. Well, is that a good thing though? Lowering paperwork. Maybe that's a good thing.
I think it's a
That
very
would be
good thing. We
great.
don't need that many administrators.
Yeah,
Yeah,
that would be a great thing.
Okay.
More
Good.
doctors, less administrators.
Okay, good plan, I think. Yeah. Oh, then you guys are making progress then. Okay, that sounds like a good thing. All righty. Well, then let's move over. Thanks for correcting me, by the way. I appreciate that. All right, then Sandy, anything that's a good segue over to you, et cetera, because there are things happening in terms of decreasing the paperwork also for emergency department folks as well, right?
Right. Yeah. So just a couple of things. First off, the meeting, that meeting in San Francisco. Looking forward to seeing you there, Paul. I have sent your abstract to our media people, and hopefully that will engender a little bit of press for you guys, along with a few others.
Yeah. Okay, good.
In terms of monkeypox, two things. Number one, I put in their chat already, the field guide to monkeypox. It's has all the information you guys need in terms of how to do swabs, who collects them, what labs. We update this daily. So if is there something that you see wrong, just shoot me a message and we'll try to update it more than daily. The other thing is we're working on an interesting project with a group called Visual DX. They have an artificial intelligence system that looks at rashes and identifies the rashes. And now they're wanting to build one on monkeypox. The problem is they need hundreds and hundreds of images. So they are asking us, whoops, I don't know what just happened here. They're asking us to upload obviously de-identified images to the website that I just put on here. Again, this is a joint ACEP Visual DX project. It's not just them. They will make this tool free to all ACEP members and probably to the public as well. But basically it is, again, they're needing just images of confirmed or highly suspicious monkeypox so that they can train their computers. I don't always understand how AI works.
Yeah.
Go ahead. You look like you were going to say something, but if not, I'm going to go one more thing.
Yeah.
The other one is we are doing a webinar on workflow work changes. It's basically entitled something like, if you don't have workers, how do you change the work? It's going to be September 15th, 3 to 4 Eastern. We're going to be mostly talking about how to change the work within hospital emergency departments. If there's interest, we can also do one on EMS. There are a couple of things. I'll give you a preview, a lot of things around documentation, a lot of things around who else can do the work. But there's an interesting abstract at Research Forum on physician-only care in the emergency department, where they're actually not doing any nursing or any even triage other than triage. So these patients get no nursing care at all. And they've really identified a fair number of patients that can just get seen by the physician and discharged. And it seems to be cutting down on the work of nurses. So that will be talked about on this webinar as well. Interesting.
Yeah, it is interesting. So, all right, we'll see how it goes. We got to find some way to get around all this stuff. So that sounds like at least a good exploratory thing to get into. All righty. Well, thanks, Sandy, and good to see you. All that. Now, how about you? Did you ever get COVID?
Negative. So far, negative.
All right, yeah,
We'll
okay,
see.
good.
And
All
by the
right.
way, Paul, one other piece of personal information. I'm
Yes.
leaving on vacation in a couple of weeks. I'm going to go up to Ron Stewart's place. I'll let you know how he's
Oh,
doing.
yeah. Fantastic. Give him my best. That sounds fantastic. And I remember us talking about that. That's great. All right. Well, have fun up there. Okay. I wonder if it'll probably much cooler weather by then, as opposed to what you're experiencing right now in Texas, right?
I would think that almost anywhere on the planet is cooler than Texas is right now.
Yeah, I know, it's amazing. It's still over 100 degrees. I'm coming back tonight, so I'm getting prepared to what do they say? To start
And for what
shipping.
it's worth, the Farmer's Almanac today predicted that Texas winter will be colder than ever.
Oh, of course. Okay. Well, we'll see how it goes then. All right. Let's see. Before I get to Eileen, I'll see if there's anybody else want to pipe in or have to get off before I let her go. And then again, our CME code today, folks, if anybody wants to put it in for me, is 15278, 15278. And also the Gathering of Seagulls, the Florida group, just again, for those who didn't get it before, is 15277, 15277. All right, so I'm trying to think if there's anybody else wants to pipe in before I move over to Eileen and get a good formal report on the latest on monkeypox. If hearing no objections, we'll move ahead. Eileen, take it away.
Okay, well, I wasn't actually planning on a big formal report on monkeypox. I was just going to go over some of the new data. And here, real quickly, I'm putting onto the chat is the number.
No, we were just going back. The point is, we were going back a little. Don't have to make it too formal. I mean, in fact, we don't like it formal. We were just going back and forth with different chat about different things because Glennis Seda was having to come up with some plan in New York City. So we were just going back and chatting a little bit about it.
I would love to know from Fiona why cases have plateaued in the UK. I think that's a really interesting point that she made.
Yes.
I also want to say that in Florida, as of yesterday, we have 985 cases, and one of them is in a child under four or less. Okay, and there are 6 teenagers in Florida with monkeypox. And also of significance is that Miami-Dade is now ahead of Broward with 387 cases.
Before I let you go on, David first, did you get off by any chance? Is David still on?
Yep, still here.
Yeah, you want to talk about your case? She may want to know about your case because she didn't hear about it, right?
Oh,
Yeah,
so, hi, Eileen. So here in Houston, we've got about 177 cases. We've got EpiLinks for all of them but one. We've got one female. She's got an EpiLink. We know how she contracted it, and she is in a household with 4 kids, and 3 of them are less than 8 years of age. None of them have symptoms at this point. And we actually had a really long conversation with the CDC about that case, just try to how to manage the family and stuff. But I'm worried about those kids potentially going to school, and should they be minimally symptomatic and mom misses it and sends them to school. A couple of those kids are really little. They're in the pre-K, kindergarten, first grade, second grade range, and there's a lot of innocent behaviors that the virus would probably love to take advantage of. And then the other group is, of course, the high school and college kids too. So if we wind up having a spread particularly within an elementary school, I'm afraid for the kids, and number 2, I'm afraid for how the community is going to react to that.
So I'm with you in that fear very much. So there's a series of new studies, some of which are unpublished at this time, that are demonstrating very high viral loads in respiratory droplets, and that you can actually, at a distance, find what looks like there may in fact be some aerosol transmission of monkeypox. So that's, yeah, I feel the exact same way, David. And there was a case reported yesterday on a child in southern Germany that was picked up as a household contact, asymptomatic, which sort of because they're possibly because they're just picking it up early because they're inspecting the families. So we have to see how each of those cases progress one way or another.
Let me ask you this, Eileen. What is your, I guess, I don't know what the right word is, your speculation is that if it is airborne, like you're saying, do you inhale it in your lungs and get it that way? And how do you come down? What are your symptoms? Or is it going to be something different? Or is it just get on your skin or mucous membranes and you get it that way? What do you think is the possible?
Yeah, Paul, those are really important questions. And I see that John Jew, thank you so much, John, you're magnificent. You put up an old paper from that smallpox case of at a distance, getting it by aerosol. And I think that's a really important old paper that you put up there, John. The data has always been that orthopox viruses are inhaled, and you can inhale them and get infected that way. And then the virus, you become viremic, like most viruses, goes to lymphatic areas. And then from there, based on the tropism, is going to settle into either mucus or skin, and particular parts of the skin and mucus areas, again, due to viral tropism issues. So to not put too fine a point on it, we have to really be very careful. Just as John said weeks ago when we first started talking about this, that our first responders prepare themselves for monkeypox cases exactly as they have for COVID, wearing PPE appropriately, because that's a serious problem. The other thing I want to address today is the vaccine idea that's going around. And to do that, I'd like to just play Professor for a minute and show you 4 slides. May I do that?
Sure.
Okay.
Julian, are we set up to do that where she could share?
If I can share the screen, I can share the screen. Okay.
Okay.
So right now,
you go.
I'm going to share my screen. That was just the Florida data. So this is really standard medical school stuff. But in order to get the whole idea of what they're doing with the 1/5 dose, it's best if you guys understand the history. And since not everybody remembers the history, I want to make sure everybody does. So the idea of using a different virus altogether, which is what we have done. These vaccines that we use for smallpox and monkeypox are not modern vaccines at all, in the sense of it being an attenuation of the actual, virus that causes disease, or a dead version, or proteins from the actual thing, or even messenger RNA from the actual thing. It's nothing like that. It's that way back in the day, we were using smallpox itself from milder cases and giving smallpox to people. That's called variolation. And then in the 1700s, the best known story is that of Dr. John Fuster, who was going around giving smallpox to people, variolating them to protect them against a serious case of smallpox. And you just imagine how dangerous that was. And he ran into a set of brothers, and one of them would not get any reaction. And the young man said, well, I haven't had smallpox or great pox, because they didn't understand that syphilis, was a completely different thing. But I have had cowpox, and that got Fuster to thinking. And then he noticed more and more people who didn't get a take from variolation if they had had cowpox. Now, it turns out that cowpox is, of course, a misnomer, because it's a rodent orthopox virus. It's not, and cows hardly ever get it. And we see it a lot in cats. So philids are actually a big problem with getting orthopox, and it's a problem for veterinarians as well, right? Anyway, he went to a dinner meeting, and in that dinner meeting was Edward Jenner, the famous Edward Jenner, and he told them about this idea. So that's why Edward Jenner remembered that, okay, and then said, well, let me try it. And so he took a lesion from a woman who had allegedly gotten it from a cow and put that onto this little boy, and then did something today completely unethical, gave him, exposed him to real smallpox, and the kid did fine. And he did that a few more times. And then he, with his own money, published the study, and that got this whole thing underway of using a different virus that's a related virus to protect you from smallpox, okay? Because it was safer than actually using smallpox to protect you from smallpox.
Right.
I don't know how much. Now, it wasn't actually, but what turned into what we now call vaccinia, the question is, what really was it? So on these farms, there were both horses and cows that had orthopox virus infections, and there was a disease called horsepox. And in those days, there was no germ theory, there was no concept of a virus whatsoever. So they basically mixed them up, right? And they would then actually passage them from person to person. There was no refrigeration. How do you transfer this thing from point A to point B and it not die or whatever? They didn't even know what they were doing, right? And so they passages from human to human. And the studies show that what we call vaccinia, and there's many different clades of this vaccinia virus, is a descendant of a mix of horsepox and cowpox and human passage, and that became all these different clades of vaccinia. And this is just to remind you how this vaccine was taken around the world by direct human-to-human transfer on the arms of orphan boys. So one boy gets the lesion, then you give it to the next kid until you get the vaccine all over the world, right? Okay, so then
Can you go back to that last slide?
Sure.
I think an important takeaway here is that in 1803 that they left on the Corvette, which apparently was not a sports car. It was a ship, the Maria.
Yeah.
That's really good. But
Okay.
I
All right,
did want to
Mr.
interrupt you.
Comedian.
I did
All
want to
right,
interrupt you for a
no
second.
worries. All right.
I want to interrupt you for a second.
Yes.
This is actually fascinating. I mean, this is all cool stuff. I've never heard this before. So thank you, Professor. I just wanted to tell you that. But keep going.
Okay. All right. So I just want to, because there's so much nonsense going around and people just don't understand. If you don't understand the history, you are condemned to mess things up. That's my opinion.
Yeah.
Okay. Now, so fast forward to the 20th century, we finally figure out what a virus is. We have better ways of culturing stuff, etc. And the different vaccinia strain and strain combinations are housed and named differently. So there is a New York City Board of Health strain, which actually included 4 subgroups. And by the time that most of us who got the vaccine back then got it, we got something called Dryvax, which was derived from the New York City Board of Health conglomerate of vaccinia, which is again a foreign virus, not smallpox, not monkeypox, okay? And basically it was being grown in calf lymph nodes, right? The lymph nodes and the lymph, right? And this was then what was injected, and this was what was full of pus and hair and goo and all kinds of stuff, okay? And, we estimated the value of a batch by seeing how many pock-forming units there were on the chorioallantoic membranes that we would look at, okay? And that's what you got with these little bifurcated needles scarifying you. And that's a generation 1 vaccine. That's what we call the generation 1 vaccine. So these are your generation 1 vaccines. What is a generation 2 vaccine? So generations after this Jennerian idea of using an alternative virus that, yes, we sort of modified ourselves a little bit by mixing cowpox with horsepox and human transfer, we then decided that it might be a good idea to clean it a little bit before giving it to people. And so the idea then was to passage it once through something else, like either rabbit kidney cells or chorioallantoic membranes of chicken embryos, which was done by several different types, And that was your classic second generation vaccine. More recently, and actually very recently, a Canvas Labs, all right, started the idea of using a purified clone. So instead of this mix of vaccinia strains, they found one that was least likely to cause neurologic damage or myocarditis, and that was what they called clone number 2. So first they grew it on MRC5 cells, which are human fetal lung fibroblast cells, and that was the ICAM 1000, right? Then they realized they should do something different, and people might get alarmed with that, and so they started using Vero cells, which we've talked about before, are kidney cells from monkeys. So monkey kidney cells, passage 1, that's the ACAM 2000. It's still a virus that grows on mammalian cells. It's a cell that it is still a virus that reproduces in our cells. So here's a vaccine that's essentially a human-made virus, right? That is different from smallpox and different from monkeypox. That's your second generation vaccine. What about this fancy third generation vaccine? Well, guess what, folks? This is older technology than the ACAM 2000. In fact, the idea of having a third generation vaccine started in 1931, when we knew from studies done by Pasteur and many others that when you passage a virus or a bacterium in a different host, it changes, it adapts so that it works better, so that it survives better in that host, right? And sometimes it makes it more virulent for the human, and sometimes it makes it less virulent for the human. So you had to find just the right alternative host. So what Rivers did in 1931 is he used rabbit testicles and then chick embryos, and he used the New York Board of Health variety, okay? And what he found back then was that it wasn't as protective compared to second generation vaccines, these things, okay? So because it wasn't as protective, they more or less abandoned it. But experiments were done, and folks at Walter Reed tried Rivers methods. They created a variety. In 1968, Kemp was doing that, so saw that might be safer in people with eczema, because these second generation vaccines are very dangerous in people who have eczema. And by the way, this division is from what it's derived, not the technique, okay? But then after we declared that we were going to eradicate smallpox and we wanted to get everybody vaccinated, it became a bigger deal, this idea of having a less dangerous vaccine. So a group of Germans listed here started working on a vaccine based on a strain of vaccinia that had been kept in Turkey, in Ankara, Turkey, and passaged just like Rivers had. They started first with the rabbit testicles and they moved on to the chick fibroblast. And after 300 passages, they realized that it was safer, right? So it was more desirable, and they gave it a new name. So you'll see in the literature the name Chorioallantoic vaccinia Ankara, okay? So VAC Ankara. That wasn't stable, and by stable it means that it can, or unstable, it means that the mutations can reverse and it can become more aggressive again. So they needed to passage it more times, and they found that by 570 passages, that's it, bam, it was stable. It wasn't going to go backwards. It could no longer reproduce in our cells. And this, folks, this is the MVABM. This is the so-called third generation vaccine that people are acting like it's new and great. It's not new. It's less immunogenic than the older vaccines, but it is by far much, much safer. In terms of, we can do the same thing as they did in the old days with modern technology using genetic engineering. But the only country, and we have a version, okay, but we've not done any clinical testing whatsoever. And the only country that has is the Russians, and they call theirs the Vaccinia Delta 6 because they have removed 6 important dangerous genes that are unnecessary for providing immunity, but can cause harm to humans. So their version, if you look at it, if you give the Russian vaccine, only one dose is given subcutaneously, and it gives the excellent results, better than the MVABN. And that, quite frankly, is the way we should be moving in the United States, because it takes time to grow on chorioallantoic membranes the third generation vaccine. It takes time, and we cannot surge our capacity. So what have they decided to do? Instead of acting, instead of taking the move that way, they're so freaked out that they're going to give 1/5 of the dose. Now, what evidence is there that giving 1/5 of the dose is actually going to provide the immunity? None. However, what we do know is that there are studies from several years ago showing that MVABN, the third generation version, can at one dose give you the same level of antibodies as one dose of the second generation, like the ACAM 2000. That's it. That's what we have. And I looked and searched. Now, I saw that John Jew put up there alternative ways of giving the vaccine, and that's one of the things that they're doing, is that they're giving that 1/5 dose intradermally. And what do we know about giving the dose intradermally? Well, you're going to encounter, instead of subcutaneously, you encounter fewer Langerhans cells and dendritic cells. So the Langerhans cells are going to be in the epidermis, and in the dermis itself, you're going to encounter some of those immature dendritic cells that should recognize and more quickly react, head off to the lymph nodes, and turn on the adaptive immune system. And that's what they're hoping for with giving 1/5 dose intradermally. Any questions, comments?
Well, I just remember Herbert Hoover was our president in 1931. So that gives you an idea.
Eileen, that was absolutely fascinating. I think it's just incredible how you just pull this stuff out of your hat, saying I wasn't prepared for a formal presentation, and that's better than most of the things I've seen. Question I put in the chat, but now we'll ask you.
Yeah.
And that is, we have been asked, or ASAP has been asked about people who got the childhood vaccine and then got redosed in 2001 during that campaign. Do we have any idea whether those people would need another vaccine if they were working with high-risk folks or became a high-risk person?
So traditionally, we've always, for example, for laboratory people, given the vaccine every 3 years, right? That's what's always been recommended. And there actually have been some interesting studies of people who were vaccinated a long time ago and were now given one dose of the MVABN, and it did show significant numbers of neutralizing antibodies with, without the full 2-dose method. And remember, the reason you even need 2 doses of the MVABN is because it's just not as immunogenic. It's not.
Yeah. Is there, I remember when we were thinking about smallpox back in 2001 and, vaccinating everyone and just be prepared. There was some history, and you may be the right person to say, is that they took a village somewhere that had gotten vaccinated like in 1850 or something in the 1800s. And then when some major rash of smallpox came through, like around 1900, that there was still relative protection, even though it was 30, 40 years later. Is that the history you know of?
About a group that
Smallpox.
was smallpox?
Yes.
I'm not sure about that particular story that you're recounting. I'd have to look that up.
But anyways, bottom line is that we think there probably is some relative protection, even if you got it 40 or 50 years ago. But it would be better, as what you're saying is that when people are exposed, they're getting it every 3 years. Is there a reason for the 3 years cycle? Let's just say a 10-year cycle or whatever.
So we're, as sophisticated as we are, and as long as we've been studying smallpox, there's more we don't know than what we do know. There's, for example, we know with SARS-CoV-2 that the main way that it gets into cells is via the ACE2 receptor, right? We know that with orthopox viruses, they have more than one type of infectious virion. They have the MEs and the EVs, and they enter the cell differently, and they can use a variety of different entry mechanisms. The reason I point this out, and it seems like I'm not answering your question, but I am, is because we just don't really know. We don't fully understand how to get the best immunity long-term for orthopox viruses.
Yeah.
But Fiona, I would really like now to get some concept, now that I've had a little chance to talk about why you think it's plateaued in the, I mean, not just because you see the numbers that they're plateaued, but what is the underlying mechanism that has led to the plateauing? Is it a behavioral shift?
I really don't know is the answer to that. I know that we have started to vaccinate through our sexual health clinics, but we haven't got anything like enough vaccine available. The next doses won't be available until September. So we know that people need 2 vaccines for it to be effective. So I don't know why. It'll be interesting to see whether we have a bit of a spike. We had Pride down in Brighton last weekend, which was massively well attended, and with a big party afterwards, and whether there's a bit of a spike after that might be interesting, but I don't know why it was plateaued.
Right. So, and we won't know for many days because you just had that event, right? And there's that incubation period.
What is a relative incubation period? That's a good question in itself. Is it varied? Is it like 3 days to 10 days, or is it around a week, or what is it?
It's more about a week to 2 weeks on average, but it can be less, and it can be, and there's been documentation of 41 days post exposure. So it really can range, but what we're saying is 21 days, right? Yeah.
Okay. So it's a classic thing is it's a little longer than some of the other viruses that we're used to. Okay, got it. And so that's the point.
Which is, by the way, Paul, it's why smallpox was always one of the big things that we would talk about in our scenarios when we were doing biowarfare things, because the idea was if a bad actor, for example, in the Paris metro or the DC metro that connects to multiple airports, releases the agent, where are you going to see the first case?
Yeah.
Anywhere on Earth is the answer. Anywhere.
Because and that was the whole point about bioterrorism in general, is that it's so insidious. It's like, as opposed to a chemical thing, you knew where that site was. Or if but if you release a bunch of Brucella, somewhere into the atmosphere, people are going to get sick at different times, different places, and you'll never know. Yeah, right. Exactly.
But with something with such a long incubation period, it becomes a real crap shot as to where that first case is going to show up.
Exactly. Right. Okay. Well, that's been really fun and really interesting. So go ahead. Question, John?
Yeah, Eileen, do you have any insight into the teenager spread? Was that household contacts or any insight in that?
So some of those teenagers are MSM and some are not. So, there's probably some household and there's probably some activities.
Okay. Now, let's say this. What are the downsides of this thing spreading even further? Okay. If they're not getting so ill, you go through it's very painful, but will you survive it? Or are we thinking that if there's enough people that get it, it's going to start mutating and then become something that's bad? Or is it all the above?
So that's a super important question. Number one is, we know from classic studies of monkeypox that the people who die, right, tend to be very young, very old, or pregnant, okay? Yeah. And it's not been in that population. We've been seeing it in a population that, oh yeah, they may have HIV, but it's under control, right? We've been seeing it in a population of young, healthy men. And so those are the least likely to end up in the hospital. Those are the least likely to end up with severe disease. The severe disease, although we have already seen some deaths, right, in multiple countries, and we saw that that HIV that was not managed in Peru, that individual died. We saw the individual who was 22 years old who in India, who got it in the UAE, who died of encephalitis with no skin lesions and no enanthema, so no oral or genital lesions either. So we're going to see some deaths even in that younger, healthier population, but that's the big risk. Is it getting into those populations that are, whose immune system is less likely going to be able to manage this particular virus?
Yeah.
That's I'm sorry.
Yeah. No, that's okay. What I was going to say is one of the things that was brought up earlier before you got on was because some of the other people are health directors that are on the call, is that we're feeling pretty strong that they may report X number of cases that Glenn talked about, over 2,000 cases in New York, for example, but there's a lot of suggestion that we're not getting, the test may actually be false negatives in some cases, and or people just not getting tested, and that the numbers are a lot higher than we have right now. So, it's not being identified. And by the way, how did the case, if they didn't have anything else, how did that case get diagnosed as being monkeypox? They were just checking everything out, the one that
because of exposure history in the UAE. So they decided that they were trying to figure out why he had encephalitis. They tested and it was monkeypox. And that's the other thing, is that we know from animal studies that pox viruses can in fact present as almost like a diphtheria, or can present as encephalitis and not have any of these classical symptoms that we're so keyed into right now as, oh, this is monkeypox. And the other thing is, because like all viruses, they don't read the textbooks, they do what they feel like it, right? And there's going to be a spectrum of clinical presentations, including asymptomatic, that are able to transmit, and that's already been documented as well.
And that's part of the point when I'm bringing it up, especially when we're talking about hospital aerosolization down the line. It was actually because that was the same thing. When we were hearing everything about COVID back around March 1st, of 2020, it's all this respiratory thing, respiratory. And then we're starting to find people who came in for their, diarrhea, or they came in for something else, and we were testing them just because we were testing everybody back then and they were positive. And so you're right, they don't read the textbooks. It could be so many different kinds of presentations. And so that the same is going to apply here, I suspect, as well. So, okay. Well, interesting. Anybody else have any questions for her, or any answers or comments? I thought that was great, by the way. So, I mean, so here it was all along. I'm thinking it's cowpox, but it really was rodent pox, right? And then, but I'm glad to hear that I'm not getting, rabbit testicles anymore, that kind of thing. And it's moved on. This is fascinating. What a history. That was great, Eileen. So good homework on that. And particularly since Edward Jenner gets all the credit, and then be able to point out that there was a even further background. It's like everything else, it's like there's a lot of people that contribute in different ways, and some people get the notoriety and some people don't. So it's very cool. So, all right, let's see. I'm trying to think if there was anybody else have any questions. That's great. And thanks, by the way, for your help yesterday, Eileen. I really do appreciate that. It was very useful for what I had at my project. So thank you. All right. All right, let's just then jump around. Angus, anything to report out of Florida? I'm sorry to catch you off guard.
No, not specifically, Paul.
Okay, got it. Well, I just want, how was your project going that you were talking about at one time, in terms of, I think some of the screening, for the folks, the workforce, right? Anything progressing on that end?
A couple of things, and I'm hoping to shortly add somebody to my team here that's going to help move that along.
All right, got it. All right, let's go over then to Rob Lowe. And Rob, can you give us a sort of you got a running estimate of what you're finding out from your triage question that you put out, the survey to put everybody? I know it's only a day old, but where are things leaning towards right now?
Yeah, so it seemed like the early results were leaning more towards the Start Smart product. There are a couple of salts out there, and then more recently, hearing more and more of the Ramp kind of stuff. And just some background on the reason I asked that, we use START and we've used it for a long time, and our regional healthcare collaborative got all of our hospitals and all of our,
Let me, in case anybody else doesn't know what we're talking about if you have a bunch of not mass casualty, but multiple casualty incidents, what kind of triage protocol do you use? Do you sort, do you whatever, there's all different, the acronyms start pretty much tell you the same thing, but they do it maybe in a different way, and maybe in a not a preferable way for some. That's all, right? And then can you tell us briefly what START is? What does that mean?
So the START program basically uses respiration, pulse, motor as your 3 questions to sort of sort out your red, yellow, green, and then obviously your deceased are sorted out pretty similar across all of them. The SALT was the CDC's federal government's version, sort, assess, life threats, and then transport. And honestly, they're fairly similar. The pushback we were getting locally as our disaster folks who kind of live in that federal world were asking us, was it time to switch over to the SALT? And we've gotten everybody on START. And the reason I asked the question was, one, just to make sure I wasn't behind the times, but it sounds like all of you are kind of in the same boat I am, which is these are all similar enough and nobody's that accurate that it's really the thought process that matters more than the specifics. And so for my personal ask, it was the pain going to be worth it? Like the switching of an entire region and trying to re-educate everyone and get everyone on the same page again. I'm not sure the proverbial juice was worth the squeeze there. And so I just wanted to make sure I wasn't behind the times, and it sounds like we're all kind of the same, that this is really a way to think about things. And once the day comes, the more minutia rules kind of go out the window, and the gestalt and treating the injuries sort of happens.
It's kind of like, it's like when you get there, if there's still ongoing hazard, get the people who are still exposed out of there, right? And then take it from there. And so, I think they're all pretty much the same, just a different way of expressing it. What's the RAMP? What's the difference there? What does that stand for?
So RAMP, and to be fair, I first heard of that from Peter when he was talking about some of his stuff, his incident out of Florida, but it's a little bit more intense. Some of the conversation that came up is, penetrating versus blunt injury and things like that. Much more of a penetrating thing. So in RAMP, it's basically, can you follow commands and do you have a peripheral pulse? If those are both, either one of those are bad or both are bad, you're red. And if both are good, you're green, and they're not really looking for a yellow or anything like that.
Yes.
And that there may be components of all of that when you're sorting these folks out. I often wondered if there wasn't a difference between blunt and penetrating anyway. So.
Well, there's other issues too, which are related to the size of the incident. When you have 1,000 people or more versus, or let's say 500 versus 13, it can make a difference too in how you're going to handle it. So there's just so many factors, and that it makes us. So I think you're on the right track. It might be worth us doing an Eagles write-up on that. That'd be kind of fun once we get it together. Okay,
it would be fun. The last thing I would say that I thought was interesting was out in New York, Glenn had added an orange category to try to catch some of the medicals that get tripped by the stress of the incident, which that was kind of unique.
Okay. Yeah. Okay. But that's sort of at the scene or after the fact, later, or I'm not quite clear about that. If it's psychological.
It was at the scene, and then it took into account what Dave Miramonte said, which is, they have the medical ones when they find, 100 people in the back of a hot truck. So we have about 20 of them. Rob, do you want me to send that out yet? 20 responses?
Yeah, I think you can. Yeah.
Okay. I'll summarize what I have, and ask others who want to contribute if they'll please contribute. We have between 20 and 25.
Okay.
The only last thing I would say is Joel had some interesting, not yet published data that perhaps SMART actually did a little bit better than SALT in the PEDS world, which I thought was interesting because folks had been looking at SALT so much that there still was some win on the SMART side.
So that's a good point then to bring up. I think that's a nuance right there. So that's cool. Okay, good.
Yeah.
Yeah, because you don't do kids as often, especially if it's younger kids. So, but it's going to happen. So somewhere, somehow, like a place like, let's say you're in Sandy Hook, just terrible. All right. Yeah. Unfortunately, the world is getting that way. All right. Anybody else have any questions or comments about that, or want to pipe in at all? Okay. Well, I'll quickly go down my list then and see if there's anything. AJ, anything you need to tell us here or like to tell us?
Tell you that I'm covering the 50th anniversary of emergency event up at the LA County Cerritos Civic Center, and Dr. Ron Stewart is being flown in to be a participant for that. So be our first chance to see him. And on our EMS cruise, Dr. Stewart is going to give the opening remarks next August when we leave from Seattle.
Oh, fantastic.
We're
And
so
for
happy
what-
to have him.
Oh, good. Fantastic then. Let's see then. Let's see who was next one. We talked to Angus, right? Then Bjorn. Dustin, anything happened out in Cincinnati?
Nothing particularly exciting, Paul. Sorry about the camera. I'm driving. We have had a few monkeypox cases here. Public health is not where we really need to be here. We don't have a great solution, despite many of us asking the question of who and how and where are we going to test the uninsured who don't have a primary care doctor. That's the public health answer here is just go to wherever your normal healthcare doctor. So we're still working on that. Very limited amount of vaccine. COVID is sort of doing what it's doing in most places, sort of stabilizing a little bit and being ignored a lot. But those are the big things there. My only thought with the triage stuff is that we do a weird thing in Cincinnati, sort of, in that we are officially on START, but we actually we teach it much more like SALT. We include formally in there the life safety interventions, and I think that has been a decent compromise for us to get the knowledge we want out there without having to try and get fire chiefs to agree to changing their system.
Okay, got it. All right. Let's then, Jeff Jarvis, anything you want to tell us about what's happening out there in your world?
Nope, not much. Just trying not to die from heat.
Yeah,
Ongoing battle.
It's also a little bit more humid down there as well, right? So that's even makes so your dew points must be off the charts bad. That's all I can say.
It's a little unpleasant. And all the water seems to be in the air and not on the ground.
Yeah, that's where I am today. I'll tell you that. But I'm going to go back into the fire, from the frying pan into the fire, so to speak. Okay, well, that's great. Well, thanks. Good to see you, Jeff. Let's see, who am I missing here now? I'm just trying to just run through the list here. John Kramer, never want to miss you. Anything you report from your end or anything we should know about?
No, Paul, nothing really new that I know of from NHTSA. They're still working on the grant program and pushing that really hard.
All right, and then and thanks a lot. I think I don't know if you got contacted yet by that reporter about the blooded CMS, right? But I think she's going to be, just so you're aware of that. Okay.
Yeah, we're going to be talking later this week.
Oh, fantastic! Then that'll be great, because that's something we really need to get done. That would be fantastic. Then. All right. Let's see, John, Jeff, blah, blah, blah. Mark Carnarado, anything to report out of Minneapolis?
Not currently. We are starting to see monkeypox in all the local hospitals, but not many. COVID is present, but blessedly not many people really sick with it. They just have it.
Okay, got it. Okay, Terry Valenzuela, anything on your end? Looks like we're starting to lose some of the crowd anyway, so. Terry, are you there? Yeah, he just has to find his button, I think.
Yeah, I'm here. No, nothing to report.
Okay, thanks a lot then, Terry. Appreciate that. How about you? You guys see temperatures in the sometimes in the hundreds there, don't you?
Sometimes the tarmac gets so hot that the planes can't take off because the wheels would melt.
Yeah, and you can't get enough lift too. That's so it's amazing. So you're probably going, what are these guys complaining about, right? But it's a dry heat, right, Terry? Is it a dry heat? That's
once the heat gets over 105, the humidity doesn't matter anymore.
Yeah, exactly right. All right. Well, listen, anybody else want to pipe in or say anything before I let you all go? Sounds like we had a good cover. That was a great day today. Thanks. Always good information. It's always in different ways every year, every week. So I appreciate that. If not, anybody else want to pipe in? If not, we'll let you all go. Thanks again, Eileen. Thank you for another fantastic discourse and information from everyone else. This was a good meeting. Thank you very much. See you guys next week. Welcome back, my friends, of the show that never ends. Next week, we'll see you. Take care. August 16th.
Bye, all.
Thanks, Paul.